Hi everybody, thanks for your attention. We're going to go ahead and get started. Thank you guys for joining us for another installment of our Every Possible Medicine Grand Rounds. Before we begin, just take a moment to silence your cell phones and pagers or speaker. So today we have two speakers today. We have both one of our own, Dr. Annie Linker, and then also we have a special guest from South Nassau Hospital, our Chief of Trauma Surgery there, Dr. Carina. So she has a long career both in breast surgery and also trauma surgery. Before working at South Nassau as the Chief of Trauma Surgery, she was also at East County doing trauma surgery there, and will soon be moving to Whitehall Hospital to run their Chief Trauma Surgery there as well. So today we'll be talking about complications from rib fractures, which we've unfortunately had a few morbidity events related to that, so we wanted to bring attention to this issue because we do often see those patients on our services. So with that, thank you very much, and we'll have Dr. Baker begin.
Okay. All right, so I'm just going to spend a couple minutes going through a case. I think a few people have heard about this particular case, but as Andrew said, now a few of us have started sort of collecting some of these rib fracture cases, and I think in particular, some of these patients are admitted to medicine, so it should be, it'll be good to sort of expand all of our knowledge about how to manage these patients. So I'm just going to first go through this case. This is a patient who a few of us cared for and who I was taking care of sort of at the end of her hospitalization here at Sinai. So this is patient EM. She initially came to the emergency room on January 4th of this year. So just a bit about her. So she's a 77-year-old with a history of anxiety. She was taking Xanax at that time prescribed by her primary care doctor, AFib with a low TRADS-VAS, not on anticoagulation, a history of osteopenia, which is just sort of in the chart, but no prior fractures. Kidney stones and hypertension, who initially came in with left-sided chest pain after a fall. So she describes that she's like previously fairly well, was in her usual state of health. She's the primary caregiver for her husband, who's disabled with fairly severe Parkinson's. So she was helping him get around, and she fell against a metal garbage can. She denied any head trauma with the fall, denied any like sort of central chest pain or dizziness prior to the fall. Afterwards, she noted she had extreme left-sided chest pain that was worse with inspiration and movement, but she was able to ambulate after the event. So just a bit about her initial labs. Her initial vitals were fairly stable. Her initial labs were significant for, on her CBC, a white count of 20.9, hemoglobin of 12.1, and platelets of 228 with an initial MCV of just over 100. Her electrolytes were normal. She just had like the point of care testing, so she actually had no formal basic metabolic panel at that time. There was no creatinine on it. With an INR of 1.2, and her LFTs were normal except for just a mildly elevated ALK phos and GGT. She had some initial imaging. So initially she had just a plain chest x-ray, a PA and lateral that showed concern for fractures, and then had a rib series done that showed acute minimally displaced fractures of the lateral 7th, 9th, and 10th ribs. And they said with a possible fracture of the anterior left third rib without any evidence of pneumothorax. So at that time, she was being cared for by a PA in the ED with a attending overseeing them. They noted in their notes, it says they called thoracic surgery for admission for pain control, and that they were called back and said that because there was no pneumothorax, pneumonia, pleural effusion, that the patient should be admitted to medicine as opposed to the surgical service. There's no note left by thoracics. So I think just like a brief pause here in terms of just like show of hands, like how many people, if you have taken care of a patient who has like minimally displaced fractures of multiple ribs on a medicine service, maybe like raise your hand. Yeah, so I think like it's not uncommon that we're called to admit these patients and to take care of them. So she's admitted to medicine and brought to KP4 fairly quickly. Is given pain control with some combination of Ketorolac, low-dose Percocet, occasional low-dose IV Dilaudid and lidocaine patches, and notes an improvement in her pain by the next day. She's transitioned mostly to Tylenol overnight with just some like low-dose Dilaudid for breakthrough. And then she's noted to have sort of, she describes being unable to urinate, and she's noted to have urinary retention. Then with a BMP showing a creatinine of 1.79 from the prior baseline in our system had been about 0.8. So at that point, she had been thinking about wanting to go home, but a Foley catheter is placed, and her creatinine improves with the Foley. So just monitoring of her other labs. So January 4th, we talked about her initial presenting labs. On the 5th, her white count comes down to 18.4, and her hemoglobin comes down to 10.9. and platelets also come down. And then the following day on the 6th, again, like everything comes down a bit, and the hemoglobin now is 7.9, the white count is 11.9, and platelets are 128. So because she's noticed to be anemic, a portable chest x-ray is ordered. And the patient reports that she's feeling like significantly improved compared to admission. She was very concerned about getting home to her husband and the fact that she was really the person who's taking care of him, and said like she felt pretty much better. And at this point, she's able to walk around her room. So this is her chest x-ray that's ordered then. So at that time, like talking to the team managing, I think some of the things, and I saw this chest x-ray the next day, just so she has these left-sided rib fractures, and in terms of like her claustrophrenic angle and just like this area around here, sort of what we were looking for, like does she have a hemothorax in terms of her anemia, it looked like pretty good. And so it's read as having a small left-sided pleural effusion. I actually called radiology and they were like, it's very like minimal and like not that impressive. So this is just like the ordering information that's put on the chest x-ray. So just to say they did call this left-sided pleural effusion. So then on January 7th, so remembering she was admitted on the 4th, her hemoglobin goes from 7.9 the day before to 8.1, white count stays stable around 11, and platelets are stable at 133. And then on the 8th, her hemoglobin is 8.4, 11.7, and 150 for platelets. And her MCV through this whole time is elevated around 100. She denies any history of alcohol use. So her vitals also during this time have been stable. Her heart rate, she'd been off her Xanax for the most part while in the hospital, but her heart rate was in sort of the 90s to like occasionally in the low hundreds. Her blood pressure remained like pretty good, sort of like in the 120s to 140s, over 50s to 70s. And then she's saturating well on room air, so she's 94 to 98% on room air. At this point, she had stayed in the hospital mostly because of like monitoring the hemoglobin, but in addition because we were working to set up some home services and just get in touch with her daughter, that which had been challenging. So at that point, I sort of like sat and talked to her, and she said she had this very significant history of anxiety, but had missed her recent primary care appointment due to something going on with her husband, and had plans to follow up with her PMD post-discharge, but sort of requested that she just have a short refill of the Xanax because she couldn't like get to another appointment for another about 2 weeks. The other thing that she said is that she was told by her primary care doctor, who's not in our system, that she had this like significant anemia that needed to be worked up, and that she had been told several times that she needed to go have additional testing done, but just hadn't done it yet because like things had been busy caring for her husband. At that point, I called her family like twice that day, didn't get a call back, called her primary care doctor, didn't get a call back. And so she ended up being discharged home with a short course of Oxy 5, PRN pain, and Xanax just 0.25, PRN anxiety and primary care follow-up, and VNS for home services. And we talked a lot about the risks of using like opiates and benzos together. So at this time, she's like, her Foley's out, she's ambulating in the room, her creatinine's gone back to normal. She still has some pain at the site of her rib fractures, but is able to like use the incentive spirometer and all that. So several hours later, she feels drowsy at home and EMS is called. So this is all from the ED notes, and they also spoke to her daughter. They said she went home and sort of wasn't feeling well and started to feel kind of sleepy. Noted that she continued to have some pain at home and she was taking her pain medication. EMS came, and while they were putting her into the ambulance, she actually lost pulses. And so she arrested for about a minute. The rhythm at that time was unclear. They weren't able to get a good rhythm strip. They actually didn't give any meds, and they achieved ROSC and brought her to the ED. She also got 2 milligrams of Narcan through an IO that were given by EMS. And post-code, she's awake and biting on the ET tube. So on arrival, she's responding to pain. She's already intubated. She's given fentanyl and Versed for sedation because of the intubation, and then she like immediately becomes very hypotensive, and Levophed is started. The initial labs start to come back, and a point of care hemoglobin is 6.7. So she's accepted pretty quickly to their ICU, and a stat pan scan is done, and it shows what they call like a shattered spleen. So a large splenic hemorrhage. She's taken to the OR for an emergent XLAP and undergoes massive transfusion. Admitted to the SICU, and her course is pretty complicated, where she requires a take-back XLAP. And she's in the SICU actually for several weeks, and then is discharged to rehab on the January 31st, and actually now she's back at home with her family. And at least per like the notes in the system seems to be functioning close to her old baseline. But she has like, maybe not close to her old baseline. They have like 24-hour home help for her and her husband. So that's the case in terms of kind of what we know about it, just facts-wise. So this brought up obviously a lot of questions. I think one thing for me, when I actually found out that she was readmitted, like within hours of her being readmitted to St. Luke's. And I initially, and we'll talk about some of this, but I was initially concerned, I think from a medicine standpoint, mostly about like the combination of opiates, benzos, and she had been drowsy at home, and like I hadn't been giving her the Xanax while she had been in the hospital. And she went home and sort of had that at her disposal plus the opiates. But then a couple of other issues were brought up from a trauma perspective that I think Dr. Biggs can elucidate more. There were things that I think some of the medical team weren't quite familiar with in terms of just clinical syndromes. So that's sort of the end of the case. So we can probably move on then. Any questions sort of about that so far? Okay.
So I was really happy to be invited to come to speak here because what we do sort of is a team approach when we take care of elderly people with blunt trauma. Mount Sinai is not a trauma center, it's not a trauma hospital, so you won't get patients with gunshot wounds and stabs who come here. EMS is actually not allowed to bring them to a non-trauma center. But because the area has a lot of elderly people on the other side, patients who fall are going to be brought here. And I love Mount Sinai. I have a lot of respect for this hospital. I was on staff here. I had immediately got brought in 2015. I had it here. My daughter was born here. So I don't mean to say anything critical about Mount Sinai, but it gives very good care, but it's not a trauma hospital. Despite that, those patients are going to be brought here. The people are going to take care of them. So I was really glad to come here to give this talk. I made my presentation a bit broader, perhaps, because although this is a great case to present, this woman is elderly. She had a delayed splenic injury. She had rib fractures. These are the common things that you see in elderly trauma patients, but traumatic brain injury is also a common thing that we find. Patients who have a minor fall, off the toilet bowl after a Valsalva maneuver after a trip. A lot of elderly patients are on anticoagulants. They have pretty bad bleeds, and then hip fractures and femur fractures, which I suspect you'll see frequently here too. So I'll just give a little bit of the background. We'll talk about elderly trauma, and then I'll talk about the evaluation and current management. This is casual. I'm wearing my jeans. I'm just coming from playing tennis, which is why my hair is wet. So please stop me and ask me questions. I'm glad I'm not giving this talk in a more formal way in a suit, because that would be a drag. All right, so here we go. So elderly patients overall do worse after a traumatic injury, whether it's a penetrating injury or a blunt trauma. Just to go back a bit from when you guys were in med school, the penetrating trauma is gunshot wounds and stabs. Blunt trauma is what we see much more frequently. 80 to 90% of patients across the board in the United States suffer blunt traumatic injuries, either from car crashes or falls. So that's what we're going to be focusing on here. Why do elderly people have a worse prognosis? Mainly because they have pre-existing conditions. They often have a diminished physiologic reserve because of their age or conditions, and often they're on either antiplatelet therapy or oral anticoagulants. So the optimal care comes from a combined approach with trauma and geriatrics / internal medicine / hospitalists, whatever type of people the hospital has to provide for those patients. And right now, the American College of Surgeons mandates that any trauma center, whether it's level 1 or level 2, actually have internists on board actively involved in the patient's care. That's simply because the outcomes are better. What elderly people need, and we talk about elderly, I'm choking as I say this because my birthday is tomorrow. So we're going to call elderly age 65 and over, okay? We're not going to talk about anything under age 60 when it comes to elderly. But they require more intensive monitoring from the start, okay? And it doesn't necessarily seem like it, because typically these patients will look good in the emergency room. A 70-year-old lady who falls, has some rib fractures, she probably looks great in the ER. But the thing is, their complications develop 2 or 3 days later. And what we have found is that if they're admitted to either an intensive care unit or a step-down unit, whatever your hospital has that has a higher level of care, they actually do better simply because their complications are identified within an hour or two versus the day later when, the intern tells you, at 11 o'clock in the morning, Mrs. X had a fever or is short of breath. So, what's different about the older patient in trauma? Firstly, the resuscitation is different. It's really hard to resuscitate them. In a young, healthy trauma patient, 25-year-old athletic person, you can give them 5 liters of fluids in the emergency room. They do fine. Their urine output goes up, and that's all that matters. You do that to an elderly person, all of a sudden they're in congestive heart failure and are short of breath. And that's because they have a lower or insufficient cardiac output, which they're pumping out against a higher peripheral resistance. So they're much harder to resuscitate. These are patients particularly who shouldn't be getting a whole lot of crystalloid. If they need blood, give them blood right away. The days of giving somebody a lot of crystalloid are over. We've learned, through Iraq and through Afghanistan, that giving somebody 5 liters of crystalloid as they come into the ER, actually makes them worse because you're taking someone who's lost blood and you're diluting their clotting factors and their platelets even further and giving them a dilutional coagulopathy. So massive transfusion is vital in these patients. Solid organ injury, whether that be liver or spleen, generally these patients don't do as well because of bleeding. The hip fractures and the femur fractures, they're a bit different. Femur fractures, they bleed. At level 1, 2, 3 trauma centers, every femur fracture has to be admitted to a surgical service because you can lose up to 800 cc's of blood in the thigh before the patient gets to the operating room. Hip fractures, these patients tend to bleed less unless it's a complicated pelvic fracture on top of it. Hip fractures don't necessarily need to be followed as closely by surgery because they tend to bleed less. The ideal is to get the patients with hip and femur fractures to the operating room soon. If it's a young person, they should go directly from the emergency department after they're resuscitated to the OR. And that might take a few hours. There's time to consent them, get them typed and crossed, optimize them, whatever needs to be done. The thing is, an elderly person who comes in after a hip fracture or a femur fracture, they might not be a great surgical candidate. They often come in with coexisting conditions. They may have had an episode of dizziness, or they may have had an MI that caused them to fall in the first place. So unfortunately, they don't necessarily get to the operating room as quickly as a younger patient, although they should. Simply because as soon as they have their operation, they can be up ambulating, and then you lose the or the risk of respiratory complications is much lower. They have a lower risk for PE, lower risk for atelectasis, lower risk for pneumonia when they're sitting up in a chair or already ambulating with physical therapy. What really does these patients harm is when they're sitting in the hospital for 2 to 3 days waiting on their operation, because that's when their complications accrue. Rib fractures are the most common thoracic injury in trauma. It sounds like they are one of the more common injuries that you see. It's really recommended that anybody over the age of 65 with 1 or 2 rib fractures be admitted to the hospital, simply because you can give them better pain control in-house than at home. They get more aggressive pulmonary toilet. And the thing that actually leads to their demise, pneumonia, is going to be detected much sooner if they're in the hospital than if they're at home. Traumatic brain injury, we see that commonly. Elderly people get lightheaded, they get dizzy, they fall. There's a paper called Why Do They Fall? And it seems like it's very common, ataxia. There are a lot of medical conditions, I don't know what they are, but they all seem to fall and come in and have traumatic brain injuries. And as you know, a lot of these patients are on anticoagulants that make the bleed worse. So what's different about these patients, even if they come in after a fall, they've had a loss of consciousness, they come in, they have a head CT, they're neurologically normal. You see them, you're talking to them, their GCS of 15, the head CT is negative, but they're on aspirin or they're on apixaban, they're on all kinds of things that can cause them to bleed. They can't go home because about what we The trend in the trauma literature is that about 2% of them will have a delayed bleed. And the elderly people are even more prone to that because they have cerebral atrophy. So the bridging veins in the subarachnoid and subdural bridging veins, they're more likely to tear. So even these patients, if they have a GCS of 15, normal head CT, if they're on anticoagulation, they need a repeat head CT about 8 hours later, and they need to be observed neurologically for that. Okay. And then they can go home. They don't need to be reversed unless they have a bleed on scan. So the rib fracture patients, like I said, they look a whole lot better initially when we see them than a few days later. Obviously, there are certain criteria that require a higher level of care. Obviously, if they're on a ventilator, they should go to an intensive care unit or to if you have a step-down unit that manages vents. If they have other major traumatic injuries, they should be in a unit. If their O2 sats under 92%, that's concerning. They should be in a more monitored setting. If there's any underlying lung disease, or if they're age over 65, they should be in a more monitored setting. They should not be on the floor. I don't have level 1 data to support this, but these are guidelines, and to the best knowledge that we have, these are the recommendations from the Eastern Association for the Surgery of Trauma, the Western Association for the Surgery of Trauma, and the American Society of Surgery of Trauma, which are the major societies that make guidelines for trauma patients in the U.S. All right, so what do we do with the patients with rib fractures? If you make a decision for them to go to the floor, and that's a clinical judgment call, and it also has to do with whether there's availability of unit beds, right? You're going to have a hard time telling a surgical intensivist that your patient needs to go to the unit for rib fractures when they have, somebody coming out of the OR after much more severe injury or much major operations. But if they go to the floor, they should have vital signs more frequently. They need to have a pulse ox on their finger. Goal is to maintain O2 sats, as you know, in the 90s. They need very aggressive incentive spirometry and chest physical therapy. If they have wheezing or smoking history or COPD, they need bronchodilators. Often these patients will have some trouble swallowing. It's not clear why the swallowing mechanism in elderly patients is affected when there's an injury above the diaphragm, but it seems to be. So you may consider having some type of swallow study before you start to feed them. Not necessarily straightforward with rib fractures, but an elderly patient who has a cervical spine fracture, even if it's stable, somehow their swallowing mechanism seems to be affected, and they're more likely to aspirate. I think these other, I'm talking to internists, so I don't need to you all are familiar with this, but pain control is super important in the rib fracture patients as well. Where did I go? As far as pain control, I just want to say a few things about rib fractures. The ideal analgesia is an epidural catheter. Asking the anesthesiologists to place it. Sometimes most of the places I've been, the anesthesiologists are busy, but it is the optimal pain management for patients with rib fractures. It's also much more cost effective than giving IV medication and oral medications for several days. If you can get an epidural catheter in the patient for just 2 days, that gets them over the worst of their pain. And then you can give what you gave this lady. Lidocaine patch is very effective. And then obviously we prefer to give non-steroidals instead of narcotics for many reasons. Okay. Next, splenic injury, which is what this lady's major issue was. The spleen is the most commonly injured organ in blunt trauma. So in a patient who has rib fractures, especially on the left side, always have to consider that the spleen probably was punctured or suffered a blunt injury associated with that. The bleeding can be immediate in a patient in the emergency room, or as this lady presented, the bleeding can be several days out. Most patients with splenic lacerations, either blunt or penetrating, bleed within the first 8-9 days of the injury. So what are some of the causes of delayed splenic rupture? It's not clear whether this lady had an immediate or delayed rupture. She was normotensive when she was in the hospital. She had a normal hematocrit, so it's unlikely that she had a bleed at that time. probably was a more delayed rupture. This can be from a missed diagnosis. If a patient has rib fractures, an elderly patient with rib fractures, the trend today in the trauma literature is to recommend a CAT scan of the chest. Okay? A plain X-ray of the chest is a nice screening tool in a young, healthy trauma patient, because if you miss 1 or 2 rib fractures, it's not the end of the world. But in an elderly patient, generally, if they have 1 or 2 rib fractures on a plain X-ray, if you get a chest CT, you'll upgrade the number of rib fractures that you'll see. And it also will allow you to identify a small hemothorax or a small pneumothorax early. And that's something that's important to know on admission. Rib series are out. They're, sorry to say, they're outdated. It's not something that's useful anymore. All that a rib series does is gives you an AP, a lateral, and oblique view of the rib. CAT scan of the chest gives you sub-centimeter cuts. It upgrades the number of rib fractures. Anyone who has rib fractures on the lower left ribs should have a CAT scan of the upper abdomen as well to get a look at the spleen. Anyone who has right lower rib fractures should have a CAT scan of the upper abdomen to get a look at the liver. Okay. So the missed diagnosis can be from not getting the ideal imaging in the emergency department, or it can be done if the CAT scan was done without contrast. When we get CAT scans of the chest or abdomen in trauma, the main thing that we're looking for is bleeding. So if we don't give IV contrast, then we don't know if the patient's bleeding or not, and then the CAT scan simply has to be repeated. I understand that we're concerned about contrast-induced nephropathy. The incidence is 2%. That number comes from the angiography literature from 15, 20 years ago. That was done on older people who had coronary artery disease. It was usually a radial artery stick, so there was more diffusion of plaque. So those patients had a higher incidence of contrast-induced nephropathy. Certainly in the elderly population, it's something to consider. Somebody comes in and they have a baseline creatinine of 2, then you really have to weigh the pros and cons of whether or not you're going to give the patient the risk of a contrast-induced nephropathy. But if there's a concern of bleeding, that risk may be worth the benefit. Failed non-operative management. I'm going to talk about operative choices, operative and non-operative management. Today, 80% of patients with splenic injuries are treated conservatively. That means they're admitted, followed with serial hematocrits, serial abdominal exams, and they don't get an operation. That doesn't mean that they all do well. A certain percentage of those will rebleed. If you take the spleen out initially, it's very unlikely that that happens. Okay? So certain patients who have known splenic injuries and do well with non-operative management may still bleed further out. Another possibility of delayed rupture is colonoscopy. When the colonoscope goes up the left colon and is pushed around the splenic flexure, there's traction between the ligament that connects the splenic flexure to the spleen. What happens is that you can get a capsular tear on the spleen, which can bleed initially or can bleed later on. Pseudoaneurysm is simply a false aneurysm that can occur anywhere, but it can occur within the spleen itself. Those are more likely to rupture. A pseudocyst is a cyst that is made of a fibrous capsule to contain a splenic hematoma. Those can bleed in a delayed fashion as well. So there are a lot of reasons that this patient or any other patient can have a delayed bleed. All right. This is one of many papers. Some obscure hospital in Midtown I think it's called Bellevue or something. The trauma surgeons there published this in October in the Journal of the American College of Surgeons, where they just looked at about 5,000 patients in the National Trauma Database who were treated with blunt and who were treated with non-operative versus operative management. This group had simply a blunt splenic injury, and basically the two points they make was that age is an independent predictor of mortality in both operative and non-operative groups, and that the association with mortality increases with increasing age in patients requiring operation. So how do we manage? Yeah.
So does that mean the patient's age, or if the patient's older,
That's a debate. Okay? And this data says that the older they are, the worse they do. But what we know is that the older they are, the worse they're going to tolerate a rebound. So there's a real judgment that's made, and unfortunately there are some biases. Um, you try to avoid surgery in an older person, but if they're going to bleed, you can do a quick splenectomy in an hour and get them off the table if you optimize them and have, take good care of the patient. Waiting for them to bleed is I think, in my opinion, less than ideal, because even in the best of circumstances, by the time you identify that bleeding has occurred, you either know that because the hematocrit has dropped or they're hypotensive. So they probably have been bleeding for hours. And no matter what your hospital resources are, by the time you get them from the bed into the operating room, has a lot to do with what's going on that day in the OR, what the room availability is, how quickly you can get someone. You're usually talking about a few hours delay in the best scenario. So you're going to have surgeon bias in that. A lot of surgeons will just say, I'm going to take the patient, do a splenectomy, and have a good outcome. But it really depends on a lot of things. It depends on the grade of the splenic injury, depends on the condition of the patient, depends on your resources as well. So non-operative management, as I said, 80% of patients with blunt splenic injury today are treated non-operatively with observation, and part of that may require the interventional radiologist to do an angiogram and to embolize either the splenic artery itself or the branch of the splenic artery. Non-operative management is only for a patient who's rock stable. They have to be awake, alert, normotensive, no peritonitis, stable hematocrits. Those are the only patients who are candidates for non-operative management. And that's why the number is so high. We talk about 90%, but that's this select group. A patient that comes into the ER who's hypotensive or has a low hematocrit or has peritonitis, those aren't candidates for non-operative management. You don't give them blood and then hope that they do well because they stabilize. They've already failed, and they go directly to the operating room. The options here are splenectomy and splenorrhaphy. So just a few words about age in splenic trauma. Splenic conservative management of splenic trauma was really first done in the pediatric population. It's because the spleen in a child has a much more immunologic significance than it does in an older person. So there was a greater emphasis on trying to save the spleen. Young spleens are different from older spleens. The splenic capsule in children is much thicker, so that capsule can contract and contain bleeding much more easily. Also, the parenchyma is much firmer, so that when the splenic capsule contracts, the idea is that it contains bleeding more easily than in a thin capsuled, soft parenchyma elderly spleen. So again, non-operative management is only for a patient who's rock stable, no peritonitis. Peritonitis is caused by two things, either irritation of the peritoneum from blood or irritation of the peritoneum from stool or succus entericus. Either of those cases buys you an operation. So peritonitis means an operation, even if the patient has a normal blood pressure and a normal hematocrit. If the patient has peritonitis, they get an operation. They should have no traumatic brain injury. If they have any traumatic brain injury, even a small epidural, subdural, those patients should get an operation to remove the spleen, because they're not going to tolerate hypotension because then the brain becomes ischemic, and that's a significant predictor of a worse outcome for the traumatic brain injury. They should not have multiple injuries. Why? Because they can bleed from a variety of sources, and you don't know if they're bleeding from the spleen, or from the femur fracture, or from the hemothorax. No more than 2 units of packed cells. So you have a patient with a multiply injured patient. Patient is in a car crash, he's got a femur fracture, some fractured ribs, what looks like a small splenic laceration. They're hypotensive initially, you give them 2 units of packed red blood cells because you give them the benefit of the doubt that the bleeding can be multifactorial. After that 2 units, if they're still hypotensive, they go to the OR to have a splenectomy. They're not candidates for conservation. And you also have to have the ability for close observation. You need in-house physicians, whether they be attendings or residents. You have to have an intensive care unit of some type, whether it's medical or surgical, where you can follow these patients closely. If you're at a community hospital out in a rural area and there are no physicians in-house, those patients are not candidates for conservative management because nobody's going to follow them overnight. All right. Not to torture you, but just so that we're on the same page with splenic grades. Grade 1 is less than a centimeter. Grade 2 is 1 to 3 centimeters. You can see these are small. These are the patients in the literature most who were treated with conservative management. Once you get to grade 3, you have a laceration that's either 3 centimeters or greater, or a hematoma 5 centimeters or greater. And then grade 4, these are the ones who have a laceration. They have a vascular injury to the pedicle. And then grade 5, you have a shattered spleen. There's no role for conservation here. Okay, these patients get it seems like your patient had a quick splenectomy. There's minimal role for conservation here. If this patient is rock stable, stable hematocrit, normotensive, these are the patients who are candidates for IR embolization, where this was first done with complete embolization of the splenic artery about 20 years ago when the technology first started. And then you'd have an infarcted spleen. A lot of these patients had chronic pain for weeks. The spleen would become, the hematoma would become infected, and you'd be treating a splenic abscess for a long time. And often the better treatment at that point was just to remove the spleen, the source of pain and infection. Today, what a lot of so then the trend was to just identify which branch of the spleen needed to be embolized, and to embolize that particular branch. That had a sort of, that was sometimes good, sometimes not so good. Now what interventional radiologists do is they put a coil in the main splenic artery to shut down all the blood, most of the blood coming from here, and then allow collateralization to occur. But, however your interventional radiologist likes to do it, I usually just, I don't, we don't get involved in that, but that's what's done. Yeah.
In this patient, it seems that she had the initial hemoglobin,
Mhm.
delayed hemoglobin, and then her hemoglobin was stable.
Mhm.
And she,
Yeah.
do you think that she had a smaller?
She might have, who in retrospect, who knows? She might have had a bit of a hemothorax initially. We don't know, but she may have had most likely had a splenic laceration initially, and she was in bed for the time that she was in the hospital, so it was contained. Chances are, when she got home, she probably was helping her husband, was much more active, moving around a lot, and then bled. What we recommend for patients with a splenic injury after discharge, 6 weeks of not bed rest, but really be careful what you do. No sports, no body contact for a good 6 to 8 weeks. This is just an example of a protocol. I'm not suggesting this, but this is what we did at Kings County Hospital. Grade spleens, they went to the sub-centimeters, they went to the floor. The lower grade and higher grade spleens, they went to the intensive care unit. They get serial CBCs every 6 hours or every 4 hours, depending. Angiogram for grade 1 and 2, not necessary for grade 3. Splenic lacerations and over. If they were stable, they were done electively for the 3s, but for the 4s, the interventional radiologist needed to come in whatever time of the day or night and do an angiogram and embolize the spleen. Otherwise, we would have ended up doing splenectomy. Repeat CAT scan for splenic injury is important. A lot of patients will develop a pseudoaneurysm or an AV fistula, and it's important to know that because they will bleed in a delayed fashion when they're resuming their daily functions, and that can be a life-threatening bleed. So for more significant splenic lacerations, grade 2 or greater, we generally would do a CAT scan, certainly on that hospital admission before they go home. Okay, so some of the complications of delay of non-operative management, as we know, 10% of patients with blunt splenic injuries will have delayed rupture. So this lady fell into that group. Pseudocyst is another complication. This is managed in a variety of ways. You can wait for it to resolve. Sometimes if it's a more active person, an athlete, you don't want them to get a blow to the abdomen, then you would rather drain the spleen. Another option is marsupialization, or another is simply splenectomy, just to definitively treat the problem. Pseudoaneurysm is followed by a follow-up CAT scan, and the symptoms can be variable. Often these patients are not symptomatic, or with pseudocyst or pseudoaneurysm, it can become large enough so that the patient develops nausea, vomiting, and the diagnosis is made that way. Some of the risk factors for delayed splenic rupture: higher grade. You're not going to see splenic rupture really in grade 1 or 2, but in the higher grades, you'll see it more likely. Age over 55. It's really controversial. In preparation for this talk, I reviewed the last couple of years' worth of literature. It's 50-50. I don't know if older people are a greater risk for delay, but it may be. A recent colonoscopy is something always to keep in mind. Most delayed ruptures occur within 8 hours after injury, and ideally you'd like to keep these patients in the hospital for 8-9 days, and it's very hard to get your insurance companies and all other people who are wanting to get you to send the patient home when the patient's sitting up, walking, complaining about the food. Why do they still have to be here? But if they rupture at home, they barely make it. Okay, so some of the mechanisms are expansion of the hematoma, clot disruption, rupture of pseudoaneurysm, rupture of the splenic pseudocyst, or the splenic capsule tear after colonoscopy. These patients, they can present with pain, distension, a drop in hematocrit, or in hemorrhagic shock, as your lady did. The diagnosis, we should always have a higher index of suspicion for splenic injury or rupture with left rib fractures. Pain on abdominal exam, plus or minus, especially in the elderly. The definitive diagnosis is made with CAT scan with IV contrast. And then I don't mean to go on and on about the surgical management here, but we see this in the elderly because of frequent falls, anticoagulants, and we're seeing this more and more because of the use of non-operative management in splenic injury patients. Angioembolization, as I mentioned, is for the stable patient with a grade 3 or 4 laceration. In a hemodynamically unstable patient, there's really no role for splenorrhaphy. The treatment is splenectomy. And the reason why, I've sat in these and I don't want people to fall asleep, so I just want to get my points across. Splenic salvage, splenorrhaphy. Whenever you see like 5 or more operations for the same thing, it means that there's really no agreement on one good operation. So there are different ways of patching up a bleeding spleen, which is basically what this is. You can use sutures, you can use mesh, you can take a piece of omentum and stuff it into the laceration and put some sutures over it. If it's a small laceration, yes, fine, you can get away with it. But if it's a big one, no. And if it's a rebleed or a delayed bleed, you don't mess around here. You just do a quick splenectomy, get rid of the problem, and then have a viable patient. Okay. So, are there any med students in the room? Good. So you won't get pimped. Okay. So, overwhelming post-splenectomy infection. This is often an exam question. I've never seen it. The incidence is exceedingly low. It happens in less than 1% of patients who've undergone a splenectomy. For patients who've undergone a splenectomy for trauma, for some reason, we don't quite understand, the incidence is even lower. In any case, we still treat them because of the high mortality associated with OPSI, and these patients, they can die of strep pneumonia, H. flu, or Neisseria meningitis. And what we do is we give them we consult ID, but they get their vaccine on the day of discharge. And how these patients do in the long term in terms of trauma, we don't know, because there's really no follow-up in the literature. And these are, these, I'm sure you've seen these pictures on your lady, but this is a classic image of a CAT scan. This is the coronal view of a splenic hematoma. Free blood is over around the liver as well, and this is what we see right here around the spleen. So in summary, age is a negative predictor of survival for all trauma patients in all of the categories that I discussed. Delayed splenic rupture may be multifactorial. and a multimodality approach is necessary. And I commend you for taking on the patients with rib fractures, because they're often high intensity patients who need a lot of care. Thank you for inviting me.
Thank you. Thank you, Dr. Biggs.
Sure, my pleasure.
Do you have any questions for our guests? So
Yeah.
basically, because typically we have these patients who come in routinely with falls, but so you're really saying that we should be a little bit more aggressive with our imaging modalities when they first come in and getting CTs of their chest and then also
But I think that should be done in the emergency department, so that then you have if somebody has a splenic you get somebody with rib fractures and you get a CAT scan, they have 5 rib fractures and a small hemothorax, that patient should be on a surgical service. Or clearly if they have a liver or spleen injury. It's my opinion. Yeah.
Thank you so much for your
My pleasure.
geriatrics.
Okay.
And I find this very helpful.
Yeah.
Because I do, I think we appreciate that falls is a trauma for our patients, and they're often overlooked because they're
Yeah.
so well trained. But my curiosity is at the frequent at triage of the emergency department, because essentially I know there's protocols for the number of fractures checked on them. CAT scan, and I think more often they're not getting that.
I see.
So I'm curious if there are opportunities or protocols, especially since we're not a trauma center, and I worry that these presentations are overlooked because they're not benign.
Yeah.
And it sounds like it's in different institutions, and I wonder if there's something that we can use here as efforts to improve geriatric triage.
South Nassau Communities Hospital was just bought by Mount Sinai. So you can make a strong argument to use the rib fracture protocol. Because if it's good enough for a little hospital on Long Island, it's good enough for a mothership. You're buying a lot of work for it. You're going to be taking on a lot more patients. So it's something. Each hospital, each department has to make decisions of what suits them well.
We have, I think there are efforts where we've just been running again as a geriatric emergency department level 1, so I recognize trauma when this is the regular one coming to the ED, so we're going to get that education and understanding of why we have to do things a little differently in these situations, so it may be an opportune time to introduce
What I recommend is if you Google rib fracture protocols, you'll find protocols from a lot of different trauma centers. And also all the protocols online, shock trauma. I can send you protocols. And then you can bring that to your emergency department and say, hey, let's see if we can, it's all about optimizing patient care. It's not about dumping patients on one service or another. Unfortunately, in the trauma literature, there's not really one or two data to mandate to argue for chest CT, but the trend is if you read the trauma literature, most people will get a chest CAT scan, simply because older people are osteoporotic. They're going to have more rib fractures than a young healthy person, and that's going to determine your management. And you need to know that, because if you have somebody with late rib fractures, they can't be on the floor.
that's where it's going to get
I can see the point. It's not plastic surgeons operate on the lung and esophagus. It's not their thing to manage rib fractures.
It's what I just know. A fall is just not, my older patients are just more fascinating, but I think this is
Don't invite me to your RCA. All right, thank you, everybody. Thank you for having me.